I gave this presentation to Korean Academy of Prosthodontics in the year 2010. The presentation was about rationale and the clinical experiences for using mini implants. There's three parts. I would like to talk about why mini implants are needed and how mini implants are used in clinical situations, and what kind of results are expected when mini implants are utilized. Let's talk about the first part, why part of the mini implant. It is undeniable that paradigm of prosthodontic dentistry has been changing from conventional prosthodontics to implant prosthodontics. Dental implants has proven to be highly successful. For replacement of missing tooth, when implants are used, no other teeth need to be sacrificed. It can also improve the patient's quality of life, and there are many benefits out there. However, when we do implant treatment, we have to consider many aspects, such as biology, wound healing, biomechanics, and many other things for the success of the treatment outcome. For the long-term predictable success, biological width principle must be followed and respected. Implant literatures suggest at least 1.5 to 2 millimeter of surrounding bone is necessary for long-term success. Typically, conventional implants are bigger than 3 millimeter, so you would need at least minimum of 7 millimeter of edentulous space for conventional implant treatment. Whenever I calculate the minimum space needed for a dental implant, this is a rule of thumb that I use. Diameter of the implant to replace the tooth plus 3 millimeter. If this principle is not followed, then long-term success of implant is not predictable. If you look at the size of a mandibular anterior tooth, they're small, particularly in mesial distal dimension. If a small diameter conventional implant is used to replace a mandibular anterior tooth, biological width can be easily violated, thus compromising the long-term success and potentially jeopardizing the longevity of adjacent tooth. For emergence profile perspective, it is very difficult to emulate the natural tooth emergence profile with a small diameter conventional implant in a situation where gingival recession is present. When you have to add thickness of prosthetic material to already bulky implant in mandibular anterior area, mimicking natural tooth with a dental implant can be extremely challenging. Whereas mini implant that's smaller than conventional size of dental implant, it has a better chance to emulate the emergence profile of a natural tooth, particularly when gingival recession is present. Personally, mini implants are better suited for mandibular anterior tooth replacement than conventional implant because they have a better chance to respect the biological width and to create a more natural emergence profile. Let's see how mini implants are used in mandibular anterior area. This patient has lost right mandibular central incisor tooth number 25 due to periodontal problem. As you can see, it has a limited edentulous space. It has a little over 3 millimeter of span at the coronal portion. At gingiva, crestal bone level, there are about 6 millimeter of edentulous span. To gain the space, enableplasty was performed. Planned restoration on study model is verified intraorally in patient's mouth. Flap was reflected. 2.5 millimeter mini implant was placed as planned. Because of the remaining buccal bone was thin, bone graft was performed. In this case, calcium sulfate was used as a barrier for the bone graft. Flap was advanced and sutured, and tooth-borne provisional was provided. 3 months of healing was allowed. Provisional was removed, and this is how much buccal bone was present at 3 months. Impression cupping was placed, final impression was taken, a bump was placed, and it was modified intraorally. And this is how it looked. and implant provisional was provided until the final restoration was ready. This is a working model. This is the final abutment that's been fabricated. Jig was made for the final abutment. This is a final restoration. Final abutment was transferred to the implant with the jig. The final abutment was fully seated, and the restoration was delivered. This is how it looked 1 year after delivering the final restoration, and this is 2 years after. This is the case where 5-unit cantilever bridge failed and tooth number 11 left maxillolateral incisor was extracted. Patient wished for implant treatment. An article by Buser helped me to formulate the treatment plan for this patient. The space between lateral incisor and the canine is small, and the soft tissue is also thin. There is less soft volume than 2 central incisors. 2 consecutive implant distance between lateral and canine is smaller than actual arch length because it is at the corner where the arch makes the turn. As we know, inter-implant distance is critical for long-term success. I was not sure if I could establish minimum 3 mm inter-implant distance if I placed 2 conventional implants as number 10 and number 11 sites consecutively. I thought about placing 1 implant and cantilevering the implant restoration. However, this approach is not biomechanically stable as 2-implant treatment. The final plan was to place a conventional size implant at number 11 and mini-implant at number 10. Flap was raised and 1 mini-implant and 1 conventional implant were placed as planned. I wanted to make sure that I had enough distance from the tooth to implant as well as the distance between 2 implants. Inter-implant distance was more than 3 mm apart, as you can see in this photo. Impression was taken for the provisional at later stage. Previous extraction site was grafted in an attempt to maintain the buccal bone thickness. As Grander suggested, thicker the buccal bone, inner implant soft tissue can be more stable. Provisional was provided. It wasn't the most confident provisional. While the implant was healing, new provisional was fabricated. This is how implant looked at 3 months after surgical placement. Healing abutment was removed, and the final abutment for both implants were placed. Provisional was placed. Because of the biological width was respected, sufficient hard and soft tissue can be seen in this photo. Routine restorative procedures were followed, and the final restoration was delivered. As you can see, there are 2 consecutive implants placed at number 10 and number 11 site. This is 1 year after delivering the final, and this is 3 years after. The last part of this presentation is what to expect clinically using a mini implants. I think the best way to explain the clinical experience is to going over the mini implant study that we conducted. Again, this presentation was given at 2010 and the study was accepted in 2009. In the study, we followed 30 patients who had immediate provisional using this particular mini implant system that was placed in mandibular anterior area. Final restoration was placed at later months. Because this was a retrospective study, there were many variables. Some patients had more than 1 mini implant placed. Some patients did not have any radiograph, and so on. In this study, we decided to focus on single implant that was immediately loaded at the time of the placement. There were 12 patients who had a radiograph at the time of the implant placement as well as at the time of 1 year follow-up. We measured the bone level on mesial and distal side of the radiograph at the final restoration, and the 1-year follow-up. The junction of the abutment and the implant was used for the reference points for the bone level measurement. As you can see, this is how the junction looked on X-ray. And the clinical results were that we had 100% success or survival. No implant had failed. And more importantly, no abutment has come loose. And all the implants they observed had a stable soft tissue for the entire observation period. And this is a clinical experience. Let me go over a few cases. And this is a case where mandibular lateral incisor has to be extracted, and the mini implant was immediately placed in the extraction socket. This is the abutment and the provisional for the mini implant. This is how the immediate provisional was delivered, and about 3 months later, final restoration was completed. And this is a 1-year follow-up, how that tissues and the implant looked. And this is a 4-year photos of the same implant. And this is a second case. Again, mandibular lateral incisor was extracted and the implant was placed. Immediate provisional was delivered, and final restoration was completed about 3 months later. This is a 1-year follow-up of the implant after delivering the final restoration. Another case, another lateral incisor that was placed without raising a flap, and abutment was placed, and at the same time, immediate provisional was provided. But 3 months after the implant placement, final restoration was completed. Again, this is about 1 year of follow-up in how the tissue looked. Last case. Again, mandibular anterior area, central incisor this time. Tooth was extracted. Mini implant was placed in the extraction socket immediately right after, and abutment was placed, and immediate provisional was delivered. About 3 months after the immediate provisional, the final restoration was delivered. As you can see, this is a 1-year follow-up. As you have seen all these cases, the soft tissue seemed to stay stable. The reason that it had a stable soft tissue is explained by the radiograph result on 12 patients that we followed. This is the list of 12 patients, the bone measurement. Plus means there has been bone gain, minus meant bone loss. Overall, there was about 0.18 millimeter of bone gain on mesial side and 0.16 millimeter of bone gain. There was no significant differences on mesial and distal side of the radiographic measurement. On this radiograph, if you look at the red arrow, at the time of the final restoration delivery, bone was at the level between first and second thread on the mesial side, and maybe second thread on the distal side. At the time of 1-year follow-up, you can see the bone level on mesial side at the first thread, as well as first thread attachment or bone can be seen on the distal side. So there has been about half thread gain on the mesial and full thread gain on the distal side. Stable bone level explain why the soft tissue stay the same, rather than we see typical soft tissue recession on implant cases. Stable bone level can be explained the fact that because mini implant is placed rather than conventional size implant, greater amount of bone is reserved. When occlusal stress is applied to the greater amount of bone reservoir, bone maturation takes place rather than bone loss. The lesson that we learn using a mini implant is that if you want to have a stable bone, you need to have more bone supporting the implant. Conclusion of the overall presentation is that mini-implant is a viable treatment, particularly in mandibular anterior area when the space is limited. Thank you for listening the voiceover for a presentation.